Today we're here with Dr. Donald Akers. Dr. Akers is a vascular endovascular surgeon with Premier Vascular Associates in Knoxville, Tennessee. Dr. Akers is now going to talk to us about abdominal aortic aneurysm. Dr. Akers, what is the abdominal aorta?
The abdominal aorta is a blood vessel that is towards the back of your abdomen, which carries the major blood supply. The aorta actually begins at the heart and continues through the chest and down into the abdomen. And the reason we're concentrating today on the abdominal aorta is that that is the area that most often develops aneurysmal disease. Aneurysmal disease is a process where the blood vessel starts to expand like a balloon. The best way I describe this is if you leave your garden hose out in the summertime and let it bake all summer long, and you hook it up to the water and you turn it on, we all know what happens. We've seen the cartoons where it gets bigger and bigger, and that's sort of what can happen to the aorta after time. And this is a location where that process happens, and when it does, when it gets to a certain size, we begin to worry about whether or not it will rupture, which is the major complication with this.
Okay, very good. So that's an abdominal aorta, and now we're talking about the aneurysms.
And to get back, the aorta goes down and then splits into what we call two iliac vessels that supplies the blood to the leg. So obviously, since it carries the blood to the lower half of the body, it's a very important blood vessel. And that's the area we concentrate on when we start talking about aneurysms.
Okay. So what causes one?
Well, there are a lot of things that can cause aneurysms. If you have a family history, if somebody in your family has had an aneurysm before, that is something to be concerned about. Now, I have to sort of give a little bit of a caveat with this, because a lot of people have family members, not a lot, but some people have aneurysms in the brain and think that those are related to the ones in the abdomen, and they're not. This is a different type of aneurysm. But if somebody in your family's had an abdominal aortic aneurysm before, you need to think about that in terms of yourself, and do you have them. It's associated with smokers. A lot of people who smoke can develop aneurysms. It's associated with hypertension, associated with cardiac disease and elevated cholesterol. Those are the sort of things that we look at. So and it's actually more common in men than women, although women are not excluded from it. They need to pay attention. But I used to teach the medical students, we used to call it a white male hypertensive smoking disease. And so that if in that subpopulation, you're at risk. And the biggest concern with aneurysms is it's not like an appendix or appendicitis where you have a pain somewhere. Often you never know that these things exist. If you actually look at the statistics, these things are found most commonly on screening. 90% of them are never known until they're either found on screening or they present with rupture. And that's what we're trying to avoid, is trying to avoid the presentation where they've ruptured and come in.
That's a very good point. Are there symptoms of...
There are some very non-specific symptoms. There's nothing that's what we would call an absolute, you have an aneurysm because of this. You can have a vague fullness in the abdomen. You can have some discomfort, some back pain, but those are non-specific symptoms of the aneurysm. I've had a couple people come into me and tell me they have a second heart in their abdomen because it's gotten so big they can actually see it, and they're skinny so they can see it pulsate. But by and large, they are asymptomatic, which is why screening is so important in this process, that you have to be, especially if you have the risk factors, that you get screened for this process, because you want to be able to find this obviously before it becomes a problem.
Absolutely. Now let's say you have had a screening or an event. What are the treatment options?
Well, first off, it depends on what size of an aneurysm that it is. Not every aneurysm needs to be fixed. If it's a small aneurysm, your doctor's probably going to tell you that he can follow it along. Now, it's important, if he says, if you're told that it's going to be followed along, then it's followed along. You don't get an ultrasound that shows you have a small, say, 2-centimeter aneurysm today and then forget about it for 10 years, because it can grow and expand. So it probably needs a yearly follow-up, and that's important. But if it reaches a certain size, and most of us now use 5 centimeters, that's about 2.5 inches, as an indication for fixing it. There are 2 ways of fixing it. And those are an open repair, which has been around the longest. The first one was done by Dr. Michael DeBakey back in 1950. But it's been around, and the results are proven. The second way, and the way we more commonly do it now, is the endovascular technique. And this is a way where we take what's called a stent graft. If you think, the best way to think about it is like a Chinese finger trap. If you remember those little toys when you were kids with the cloth around the outside of it. And we reline the inside of the aorta. We put this into the aorta and let the stent graft expand, and it prevents the pressure from getting into the aneurysm sac. And this is the way, for the most part now, we try to repair these things. Now, if we do repair them like this, one of the things we have to do also is we have to follow you up long term after we repair it, because there's some things about it. But you can, again, you can talk to your doctor about doing this. Okay. The choice of which way that you go is dependent upon a lot of information, the size, where it's located. And so when the doctor gets the information, he starts with a CT scan, he may do an arteriogram, he will begin to talk to you about how to go about fixing it.
Would he let you know, of course, then they would let you know that you are a good candidate because of certain circumstances?
Exactly. What we do is we go through this, and we look at it, and we go, and we talk to the patient. You'll hear terms like the neck is good, or there's a good landing zone, or things like this. The doctor will be more basic and explain to you that yes, we think we can use the endograft to fix this. And I would say in my practice now, 90 to 95% of the time, I'm able to use an endograft to fix these aneurysms. Still means an occasional patient needs an open repair. And it's not that, if you actually look at the numbers, the open repair may be just a touch better than the endovascular repair, but it's not that significant. And so if we can, we do still try to do it as an endovascular repair.
Excellent. So are there risks? Of course there are risks with everything, but are there specific risks with a stent graft?
Well, let's back up first and talk about the risks of a ruptured aneurysm. And because I think it's important to understand why we really decide to go ahead and fix this. When we fix an open aneurysm, there are risks. The risks when we fix an aneurysm electively, there are risks, but the risks are probably less than 2 to 3%. Okay. And we'll go through those specifically. However, if an aneurysm ruptures, the risks are far greater. The teaching tool that I used to use for this is, if you have an aneurysm, half of the patients never make it to the hospital if they rupture. Of the ones that make it to the hospital, half of them never make it out of the emergency room. And of the ones that make it to the operating room, half of them never make it out of the hospital. So a ruptured aneurysm, as we can tell, is a very deadly event, one that we want to avoid. This is why we're so aggressive about fixing it. So it's important to recognize why you want to find this electively, treat this electively, because of all the bad things that can happen when you do this emergently. Now, electively, yes, with any surgical procedures, there's complications, and it depends on whether you do the open or the endo technique as to what complications that you look at. The complications are small, but they're there. The things we look at are problems with your heart. Obviously, at the age people develop aneurysms, and with the comorbid conditions, the other things they have going along, those things end up making you an increased risk to having heart problems, because we use a lot of contrast material in doing this. We worry about what can happen to your kidneys, or how we can affect your kidneys while we're doing this, and we worry about surgical incisions and such as that, as we do with all surgical incisions. The open operation, it's a different set of complications because it's a bigger operation. The good part about this is, if you look out at 5 years, there's not a lot of difference between the open and the endo, but it's easier on the patient if we do the endo on the front end.
Right. So it does sound like, of course, that this is a very, very important thing that people need to think about their health, that there are screenings available, that these treatment options are there. Let's say that someone does have that stent procedure, and you mentioned follow-up. What can they expect for long-term?
It works well. There's
Okay.
still, the biggest issue with the endograft is there's still a small but definite risk of rupture. We've reduced it significantly, we've not eliminated it. And that's one of the arguments about the open repair. If you do an open repair, you've eliminated the risk. It's gone.
Okay.
But it's also carries some other things with it, and that's the trade-off. Now, what the follow-up is pretty straightforward. We usually get a CT scan at either a month or 3 months after the initial surgery, and then we get you on a 6-month or a yearly follow-up with repeat CT scans. And with those follow-ups, we make certain that the aneurysm sac doesn't change in size, that the aneurysm doesn't have any leaks that we need to be worried about, or anything like that.
Okay, excellent. Well, let's say that you have some risk, you have a family history of some sort, and you'd like to have a screening. What is the best way to go about getting a screening?
The federal government now has actually, with the advent of Medicare, will approve a one-time screening for carotid disease, aneurysm, and leg studies. They have agreed to do this. We have been pushing it for this for a while, and they've actually signed on to it. The basic screening, the easiest, the quickest screening to get is an ultrasound. And that's similar to what we're doing here today, is doing a simple ultrasound to look to see if there's an aneurysm present. If there isn't one present, then we're in very good shape with that. And if you're in your 50s and they see a normal aorta, that's probably something you could put way down on your lists of things to worry about. If they see one, at that point, if there's even a small dilatation or a small aneurysm, you probably need to be referred to a vascular surgeon, or your primary care physician, who, if he's had experience, may choose to follow you along for a period of time to then monitor that. And the most important thing is if you have an aneurysm, that there is a plan in place as to what we're going to do with it, how we're going to treat it, when we're going to treat it. That also becomes part of this, and that you're very much kept in the loop and informed as to what's going on.
Dr. Akers, thank you so much. It was very informative. Dr. Donald Akers with Premier Vascular Surgeons. Thank you so much.